Welcome back. We're really glad you're joining us for this deep dive.
Yeah, we have a pretty fascinating mission ahead of us today.
We really do. And to get us started, I want you to visualize something. I want you to think of public health like a massive, sprawling city's water system.
Right, so a huge network of reservoirs, pipes, pumps, all of that.
Exactly. Faucets, everything. Now, when you look at clinical medicine, the doctor's office, the hospital, the ER, it is basically like giving someone a highly advanced, incredibly expensive water filter.
And you attach that to their tap right when they start getting sick from drinking bad water.
Right. It is absolutely vital. I mean,
Wow.
if you're sick, you need that filter. But fundamentally, it is a reactive process.
You are essentially waiting for the disease to arrive at the house.
Yeah. But population-level public health, that is something entirely different. That's upstream engineering.
It's the act of building a massive state-of-the-art filtration plant way up at the reservoir.
Miles away from the city.
Yeah.
So that the water is completely clean before it ever reaches a single house.
It's really the perfect way to frame it. And the scale of that upstream engineering is precisely what we're tackling today. We aren't just looking at the theory.
No, we are looking at the heavy machinery of public health.
Exactly. We are going to explore exactly how we build that filtration plant. Like, how do we test prevention at a massive population-wide scale?
And perhaps more importantly, how do we translate raw scientific evidence into organized society-wide systems that actually change human behavior?
Which is incredibly hard. To do this, we are going to unpack two monumental pillars of high-income public health: community intervention trials and population screening.
And just to be completely clear on our mission today, if you are currently a medical student, a junior doctor, or maybe a public health trainee, consider this deep dive a dedicated companion piece to your active reading.
Specifically, if you're working through the Oxford textbook of global public health.
Right. We are drawing our structural framework straight from those core tenets. But we aren't here to just recite facts to you.
No, we are here to clarify the underlying frameworks, to strengthen your clinical reasoning, and to help you see the matrix behind the data.
We want you to understand why these massive decisions are made, not just what they are.
Exactly. We need to build the conceptual scaffolding. And before we dive into the historical narratives or the massive community trials or the incredibly complex math of screening.
Oh yeah, the math gets wild later.
It does. But we absolutely have to establish a firm baseline of terminology first. Precision in language is non-negotiable in epidemiology.
Right. If we don't have these definitions locked in, the rest of the discussion will basically turn to mud.
So first, we must distinguish between incidence and prevalence.
The classic stumbling block. Let's make this stick.
Let's use your water metaphor. Incidence tracks the occurrence of strictly new cases of a disease in a specific population over a specified period of time.
So it is a measure of risk.
Right. It's the rate at which people are actively falling ill. Prevalence, on the other hand, is the total number of existing cases in that population at a given moment in time.
So if incidence is the water actively flowing out of the faucet,
prevalence is the water currently pooled in the bathtub.
That is the best way to visualize it. I mean, if you have a disease that is highly infectious, but cures very quickly, like the common cold.
You have massive incidence.
Right. Water's blasting out of the faucet.
Right.
But you have relatively low prevalence because the bathtub keeps draining as people recover.
Conversely, if you look at a chronic condition like diabetes,
it might have a steady, maybe lower incidence.
Mm-hmm.
But because people live with it for decades, the prevalence, the water in the tub, gets incredibly deep.
Precisely. And understanding that flow is critical when you are designing an intervention. Are you trying to turn off the faucet or are you trying to drain the tub?
Wow. Yeah.
The second distinction we need to make is the difference between a hazard and a risk.
Which people mix up all the time.
They get used interchangeably in casual conversation constantly, but in public health, they mean completely different things. A hazard is an intrinsic property. It is something with the potential to cause harm.
Like a wet, freshly mopped floor.
Yes, a wet floor is a hazard. The risk, however, is the actual statistical likelihood that the harm will occur. And that depends entirely on exposure.
So the hazard is the wet floor, but the risk only exists if I actually decide to walk across it in slippery shoes.
Exactly. If we lock the door to the room with the wet floor, the hazard is still there, the floor is still wet.
But the risk has dropped to zero because there is no exposure.
You got it. And finally, a crucial distinction that will anchor the entire second half of our deep dive: surveillance versus screening.
This one trips people up constantly because they both involve looking for disease.
They do, but the intent and the target are completely different. Surveillance is the early warning radar.
Right.
It is the ongoing, systematic collection, analysis, and interpretation of health data to monitor disease trends across a population. You are watching the horizon.
Okay. And screening.
Screening is an active, systematic intervention. It is the process of identifying an unrecognized disease or a pre-disease condition in individuals who presume themselves to be entirely healthy.
So it is an offer made by the health system to an asymptomatic person.
Exactly.
Okay, let's unpack this. Keeping those definitions razor sharp. I want to start with the evolution of the community trial because this is where the history gets really wild.
It really does.
Believe it or not, the randomized controlled trial, the absolute gold standard of modern medical evidence, the thing that dictates almost everything a doctor does today, actually has its roots in dirt.
Literally dirt. We are talking about agriculture.
Right. It's such a brilliant historical pivot. When we think of RCTs today, we picture sterile labs, double-blinded pharmaceuticals, clinical settings.
But you have to go back to the 1920s to a statistician named Sir Ronald Fisher.
He was working at an agricultural research station, right?
Yes, conducting field trials. He was trying to figure out the most optimal ways to grow crops, testing different cultivation methods, different fertilizers, and newly developed hybrid seeds.
And what he realized was that you can't just plant one seed in one spot, use a new fertilizer, and claim it's better.
Because the soil might just be better in that one spot.
Or the sun might hit it differently. There's too much environmental noise.
So he developed the mathematics of randomization and analysis of variance. This was to prove that it was actually the intervention, the fertilizer, or the seed causing the better crop yield.
Not just a lucky patch of dirt.
Exactly. He formalized the math of causality in a messy environment. But the conceptual leap that brings us to public health happens a decade later.
In the 1930s and 40s.
Right. Rural sociologists started looking at Fisher's agricultural breakthroughs, and they asked a completely different question.
Which was?
Once we know a hybrid seed is objectively better, how do we get farmers to actually use it?
So they started tracking human behavior.
They studied how the adoption of these new seeds spread from the progressive, risk-taking early adopters to the more conservative established farmers and eventually to the rest of the farming community.
And that sociological tracking birthed one of the most famous models in all of behavioral science.
Yeah.
The diffusion of innovations model.
Which was later championed by sociologist Everett Rogers.
It mapped out that beautiful, predictable bell curve of how new ideas, new technologies, or new health behaviors spread through a population.
First the innovators, and finally the laggards.
They literally took the mathematics of crop yields and applied it to the spread of human behavior.
It's a profound realization. And as the decades progressed, the application of these concepts to human populations evolved in a very distinct chronological framework.
So if you track the historical progression, you see public health constantly adapting to the tools and crises of the era.
In the 1940s and 50s, the focus was heavily on infectious disease, but the methodology was heavily influenced by World War II.
Right, because governments suddenly realized they had built these massive, highly effective machineries for mass communication, logistics, and propaganda during the war years.
And somebody had the bright idea, what if we repurpose this machinery for public health?
That is exactly what happened. The infrastructure used to mobilize a nation for war was adapted to mobilize a nation against infectious disease.
This is the era where you see the rise of the massive, cinematic, mobile X-ray campaigns for tuberculosis.
You literally had fleets of trucks equipped with X-ray machines rolling into town squares.
Using mass media and community mobilization to get thousands of people lined up for screening.
And you see the same massive logistical coordination with the early polio immunization drive.
It was top-down, broad-scale community mobilization.
But then the epidemiological landscape shifts. As we hit the 1960s and 70s, the curve of human disease changes dramatically in high-income countries.
Communicable diseases are finally starting to plummet, thanks to those very vaccines, antibiotics, and better sanitation.
But chronic diseases are absolutely skyrocketing.
And the community trials reflect this epidemiological shift perfectly. The public health apparatus pivots.
We see community campaigns moving away from infectious disease and focusing initially on family planning initiatives, and then massively on cardiovascular risk.
The realization hits that chronic diseases aren't caused by a single bacterium you can target with a vaccine. They are caused by lifestyle, behavior, and the environment.
And that brings us to the ultimate public health success story, the blueprint for modern intervention, the tobacco control miracle.
It really is the hook for understanding almost everything else we do in public health today.
If you want to understand how to change a population, you study tobacco. Because for a long time, smoking wasn't just common. It was universally ubiquitous.
It was in hospitals, on airplanes, in schools.
So how did the public health establishment actually manage to reverse something so deeply entrenched and highly addictive?
It happened through a combination of powerful systemic levers, and epidemiologists generally categorize these into three distinct imperatives.
Let's go through them.
The first is the economic imperative. When you are looking at massive population shifts, you have to look at the money.
Right.
Historical data points to a very telling natural experiment. During the Great Depression in the 1930s, tobacco consumption plummeted across the board.
Which seems counterintuitive at first, right?
Yep.
I mean, you'd think at a time of massive stress and anxiety, people would lean harder into a stress-relieving addiction.
You would think so from a purely psychological standpoint. But economics trumped psychology. People simply did not have the disposable income to buy cigarettes.
Wow.
This inadvertently proved a vital concept to future public health economists: price sensitivity. It proved that even highly addictive, psychoactive products adhere to fundamental economic laws of supply and demand.
And modern data confirms this consistently, right?
Yes. A 10% price increase in tobacco products reduces overall consumption by about 4%.
And that 4% isn't distributed evenly, is it?
Not at all. That price elasticity is even stronger among vulnerable demographics. Youth, who have less disposable income, lower-income populations, and pregnant individuals are highly responsive to price shocks.
This realization is what birthed the modern strategy of excise taxation as a public health tool.
And taxation is brilliant from a systemic design perspective because it offers a dual benefit.
First, it directly suppresses the consumption of a harmful product.
Second, it simultaneously generates massive revenue that can be ring-fenced to fund the very public health interventions, cessation programs, and health campaigns needed to further fight the disease.
It is a self-funding intervention loop. That economic lever is incredibly powerful. But the social side of the tobacco story is just as wild. If you look at the spikes in tobacco consumption, you see massive surges during the World Wars.
Yes, the social normative imperative. During the wars, smoking wasn't just a habit. It was officially condoned, subsidized, and even encouraged by military leadership.
Cigarettes were literally included in standard soldier rations.
The rationale was that it helped soldiers cope with extreme stress, fatigue, and boredom in the trenches.
It became deeply integrated into their camaraderie. Smoking was the default social network. It was the definition of normalized behavior.
But then, fast forward to the 1950s, contrast that wartime normalization with what happened in 1954.
Reader's Digest.
Exactly. Reader's Digest, which at the time was an incredibly popular and deeply trusted publication reaching millions of households, published an explosive article titled "Cancer by the Carton."
It detailed laboratory experiments showing that the tar from tobacco residues reliably induced cancerous tumors when painted on the skin of mice.
The societal reaction was immediate and visceral. The result was a precipitous, massive drop in smoking rates almost overnight.
People read the article, they were genuinely terrified by the definitive link to cancer, and they quit.
It was a massive victory for health education.
But the victory was temporary. That's the tragic part. The drop was sharp, but the consumption curve bounced right back up shortly after.
And continued its historical climb.
Why? Because the tobacco industry's advertising machine, their cultural normalization apparatus, just kept grinding away.
A single burst of education, no matter how terrifying, wasn't enough to sustain behavioral change against a multi-million-dollar marketing industry.
Which perfectly illustrates the third and perhaps most crucial lesson, the ecological imperative.
That rapid bounce back proved to public health officials that relying solely on individual willpower and single, episodic bursts of education is fundamentally insufficient.
It's the equivalent of telling someone to swim upstream against a raging current.
Eventually they get tired, and the current wins. To create lasting generational change, you cannot just tell individuals to stop a behavior. You have to fundamentally change the environment they live in.
You have to change the current of the river.
Exactly. You must intervene in multiple settings simultaneously. This means changing the rules at work sites, in schools, in recreational facilities, and through legislative policy.
This is the process of denormalizing a behavior.
You have to engineer the physical and social environment so that the healthy choice becomes the easy default choice and the unhealthy choice becomes difficult, expensive, and socially restricted.
You systematically remove the ashtrays.
Yeah.
You ban smoking in restaurants. You push it out of the public square.
You create a society where the unhealthy behavior is no longer the default socially acceptable norm.
And that blueprint, that exact system impact built by the tobacco control movement, is precisely what public health is trying to apply today to the modern fight against chronic diseases.
Specifically obesity and the consumption of sugar-sweetened beverages.
If you look at the discourse today, you see the exact same arguments happening.
The parallels are striking. The interventions being tested at scale right now are direct descendants of the tobacco playbook.
We are seeing the implementation of taxation on sugary drinks, legislative limits on portion sizes in certain jurisdictions.
The overhaul of school lunch policies to remove hyper-palatable processed foods and strict regulatory restrictions on advertising junk food to children.
It is the exact same upstream engineering. It is the realization that if you place an individual in a modern food landscape that is absolutely flooded with cheap, highly engineered, hyper-palatable calories,
And you just hand them a pamphlet on the food pyramid and say, use your willpower.
you are going to lose that battle 99 times out of 100. The environment always wins. And I want to pause here just to frame this for you, the listener.
It's an important distinction.
As we discuss these systemic policies, taxation, regulation, industry restrictions, we're exploring this purely through the lens of epidemiological mechanics. Public health researchers look at a tax increase or a zoning law the exact same way a clinician looks at adjusting the dosage of a beta blocker.
It's a structural tool measured by its systemic response.
We are making a philosophical argument about the role of government or individual liberty. We're simply analyzing how manipulating these levers impacts the incidence and prevalence of disease at a population level.
That is the correct analytical framework. These policies are evaluated based on their efficacy in shifting the statistical curve of a population's risk factors.
And speaking of testing efficacy at scale, if we want to see how these theories of environmental engineering were actually put into practice in the real world, we have to look at the history of cardiovascular trials.
We do.
Here's where it gets really interesting. Let's talk about the titans of cardiovascular prevention trials, the true, heavy-hitting field experiments that define the genre.
In 1972, two monumental projects launched that completely changed the landscape of public health research.
The first is the Stanford 3 Community Study, often referred to as the 3CS.
The Stanford 3CS is a landmark in study design. It took place in 3 distinct, moderately sized towns in Northern California.
Now, from a methodological standpoint, you have to realize that you cannot perfectly randomize entire towns the way you can randomize individual lab mice or patients in a clinical drug trial.
You can't put a dome over a city and control every variable.
So researchers utilize what we call a quasi-experimental design.
Right, because if you run a massive TV ad campaign in one town, the radio signals and newspaper distributions are going to bleed into the next town over.
Media markets are porous.
So to control for this as best they could, they selected 3 towns that were demographically similar but isolated enough in their media markets to prevent significant cross-contamination of the intervention.
They designated one town as the control group, which only received standard passive data collection.
The second town received a massive, multi-channel mass media campaign. We're talking television spots, radio broadcasts, newspaper columns, billboards, the works.
And the third town received that exact same mass media campaign, but with a critical addition.
Intensive, face-to-face risk reduction classes targeted specifically at individuals identified as being at high risk for cardiovascular disease.
And the data point to highlight here is profound because it shows the stacking effect of interventions. After 2 years of this sustained effort, the researchers measured the cardiovascular risk profiles of the towns.
They saw a highly significant 23% overall cardiovascular risk reduction in the town that received mass media alone.
But in the town that had the mass media plus the face-to-face intensive classes, that risk reduction jumped to 30%.
It was a monumental proof of concept. It proved that you could fundamentally alter the risk trajectory of an entire community without ever bringing them into a hospital.
It showed that mass media works, but interpersonal targeted education acts as a powerful amplifier.
But simultaneously, across the globe, an even more radical experiment was launching, the North Karelia Project in Finland.
I am obsessed with the North Karelia Project. If Stanford was a test of media, North Karelia was a test of entire societal restructuring.
It is the absolute gold standard of what epidemiologists call system impact.
In the early 1970s, the region of North Karelia had the grim distinction of having the highest cardiovascular disease mortality rates, not just in Finland, but arguably in the world.
And the root cause was deeply cultural and economic. The region had a historical logging culture, which required massive caloric expenditure.
To sustain that, the traditional diet was incredibly heavy in saturated fats,
Yeah.
primarily from local dairy butter, full-fat milk, cheese, and fatty meats.
But as logging became mechanized, the physical exertion dropped, but the high-fat diet remained deeply entrenched.
The result was a cardiovascular epidemic. So the Finnish researchers didn't just walk in and put a billboard saying, "Eat less butter."
They realized that the economy of the entire region was dependent on producing the very thing that was killing them.
Right. Telling a community to stop eating dairy when their entire livelihood depends on dairy farming is futile.
The intervention in North Karelia went far beyond advertisements or individual health classes. It was total systemic, environmental, and economic change.
The public health leaders worked directly with the national government to enact structural reforms.
For example, they fundamentally shifted the national agricultural pricing structure of milk. Historically, farmers were paid based on the fat content of the milk. The more fat, the more money.
The government changed this to pay farmers based on the protein content, financially disincentivizing the production of high-fat milk overnight.
Wait, they literally changed the economic bedrock of the dairy industry to fight heart disease?
They did, but they went even further. They actively collaborated with the agricultural sector and local communities to help farmers transition away from dairy farming entirely.
They provided subsidies and training to convert dairy pastures into berry farms, utilizing the natural landscape to produce antioxidant-rich crops. Furthermore, they helped establish and heavily promoted a domestic canola oil industry to provide a cheap, culturally acceptable, heart-healthy alternative to the saturated fats deeply embedded in their cooking.
Just imagine the political and logistical friction of trying to organize that today. Hey, we know your family has been dairy farming in this valley for 5 generations, but for the good of the nation's coronary arteries, we need you to start growing berries and rapeseed.
It's incredible. It is the definition of cross-sector collaboration.
They didn't just ask people to make a healthy choice. They re-engineered the economy, so the healthy choice was the default, most accessible choice.
And the results were staggering. Over the following decades, cardiovascular mortality in North Karelia plummeted by over 80%.
It remains one of the greatest triumphs in public health history.
And the lessons learned from both North Karelia and the initial Stanford study fed directly into the next evolution. Following their success with the 3CS, the Stanford team launched the 5-City Project, or 5CP, in 1980.
This time, they scaled up massively, targeting a broader, more complex population of around 360,000 people.
And what makes the 5CP so fascinating isn't just the scale, it's the methodology. The researchers did something incredibly difficult.
They managed to accurately quantify the dose of health education.
We talk about medication doses all the time, 50 milligrams of this, 100 milligrams of that. But how do you measure an educational dose across a city of hundreds of thousands of people?
It is notoriously difficult, which is why the 5CP is so revered.
They rigorously tracked and coded every single television spot, every radio ad, every newspaper column, and every piece of distributed print material.
By aggregating this data, they calculated the average exposure rate.
They determined that the typical resident in the intervention cities received an average dose of about 5 hours per year of dedicated, focused health education.
The breakdown of that dose was roughly 67% delivered via broadcast media, TV, and radio, and 28% via print media. Okay, 5 hours a year. That sounds like a decent amount of education.
Yeah.
But here is the David versus Goliath comparison that absolutely blew my mind when reviewing the historical data.
Oh, this is a huge point.
You have to contrast that 5 hours per year of dedicated public health education against what the average adult is actually exposed to in the ambient media landscape.
Right.
The typical adult sees a staggering 292 hours per year of television advertisements alone, and roughly a third of those ads, nearly 100 hours a year, are highly produced, psychologically targeted campaigns promoting unhealthful, hyper-palatable processed food.
The asymmetry is staggering. Public health is walking into the ring armed with 5 hours of rational education to fight against nearly 100 hours of sophisticated, emotionally resonant marketing designed specifically to trigger cravings for salt, sugar, and fat.
It seems like an impossible fight. How could 5 hours possibly move the needle against 100 hours?
It does seem like an insurmountable disadvantage. Yet the data from the 5CP demonstrated that even this asymmetrical fight yielded significant results.
They achieved measurable, statistically significant reductions in population blood pressure and smoking rates.
But the true power of these community trials becomes undeniable when you look at them through the lens of health economics, specifically the return on investment, or ROI.
The entire 5CP mass media and education campaign cost roughly $4 per adult per year to administer. $4. That's the cost of a cup of coffee.
Exactly. Now, consider the economic impact on the individuals who actually changed their behavior because of that $4 intervention.
The data showed that adult smokers who quit as a result of the campaign saved an average of $274 a year on the cost of cigarettes alone.
That is money directly back into the local economy.
Okay.
And critically, that $274 figure doesn't even begin to factor in the massive long-term systemic savings in healthcare costs from averted heart attacks, bypass surgeries, and stroke rehabilitation.
From a health economics perspective, you are investing $4 to prevent hundreds of thousands of dollars in downstream medical costs. The return on investment is astronomical.
It really is.
Okay, so that covers the massive overarching community interventions, changing the environment, changing the laws, changing the behaviors of the whole population upstream. But now we have to pivot our focus.
Right, moving from the reservoir down to the neighborhood pipes.
If community trials are about changing population behavior, screening is about systematically finding hidden diseases within that population.
This is a critical pivot. And what's fascinating here is that screening completely flips the traditional, deeply ingrained clinical dynamic.
In standard reactive medicine, a patient feels unwell, they experience a symptom, they go to a doctor, and they ask for help.
The patient initiates the contact based on a perceived need. In screening, the dynamic is reversed.
The healthcare provider, or the state, proactively reaches out to a population of people who feel perfectly fine, who have no symptoms, and offers them a medical test.
And woven into that offer is the implicit, incredibly powerful promise that taking this test will benefit them. That is a profound ethical, psychological, and operational shift.
And because it is such a massive shift, the terminology has to be exact.
It does. We must firmly differentiate prescriptive screening from opportunistic screening.
Let's start with prescriptive.
Prescriptive screening, which is often called true population screening, is the systematic, organized offer of a test to a defined, healthy demographic.
Think of a national breast cancer screening program that automatically mails an invitation to every woman when she turns 50. The program seeks out the population.
Opportunistic screening, which is far more accurately described as case finding, occurs within a clinical setting.
It is when a clinician uses a routine, pre-existing interaction to run an extra check.
For example, a doctor checking a diabetic patient's feet for neuropathy, or checking their eyes for retinopathy during a standard checkup for their blood sugar.
The patient is already in the clinic. The doctor is just opportunistically looking for a related complication.
Exactly.
And this brings us to what epidemiologists call the popularity paradox. I think this is one of the most important concepts for anyone in medicine to grasp because it is such a dangerous psychological trap. The public absolutely loves screening.
They do. It is universally popular.
Because it sounds so intuitively right, the narrative is so clean, catch it early, save a life. It makes perfect logical sense to our brains. We think of disease like a fire in a house. The sooner you smell the smoke, the easier it is to put out.
And politicians love screening too. From a political standpoint, funding a new screening program is a very visible, very popular way to show they care about public health.
You get to cut a ribbon, announce a new initiative, and look like a hero saving lives.
Yeah.
But you have to look at the dark side of this paradox.
Indeed, there is a very real, very heavy dark side to screening, and it is rooted in 3 massive systemic harms: overdiagnosis, overtreatment, and the profound psychological and physical trauma caused by false positives.
You have to look at the mathematics of scale. When you test tens of thousands or millions of healthy people, errors are not just a possibility, they are a mathematical certainty.
First, let's look at overdiagnosis. Screening will inevitably identify cellular abnormalities that meet the strict pathological definition of a disease, say, a very slow-growing microscopic cancer, but that abnormality would never have actually progressed to cause symptoms or threaten the person's life during their natural lifespan.
It's the concept that people die with certain diseases, not of them.
Exactly. But here's the tragedy of overdiagnosis. Once that slow-growing abnormality is found, the person is officially labeled a patient.
And the medical system is designed to treat.
So they undergo invasive biopsies, aggressive surgeries, radiation, or toxic chemotherapy for a disease that was never going to hurt them. That is overdiagnosis inevitably leading to overtreatment. You have taken a healthy person and actively harmed them with medical intervention.
And that's just the true positives that didn't need treating. What about the false positives?
The false positives are arguably a wider systemic issue. Thousands of completely healthy people will receive a test result indicating they might have a terrifying disease.
This leads to severe, sometimes permanent psychological anxiety.
It leads to unnecessary invasive follow-up procedures, like a lung biopsy that collapses a lung and a lingering stigma or fear that haunts them for years. All of this harm is inflicted on a healthy person for absolutely zero clinical benefit.
You are taking someone who woke up that morning living a happy, completely healthy life, and by sheer mathematical error, you plunge them into the terrifying machinery of the oncology ward.
That is a massive ethical burden.
And that is exactly why public health professionals don't just launch a national screening program simply because a new test gets invented. They don't just say, we have the technology, let's scan everyone.
They are bound by very strict, heavily debated frameworks. The classic foundational framework is the Wilson and Younger criteria, published in 1968, which have since been expanded upon by modern bodies like the UK National Screening Committee.
The Wilson and Younger criteria represent the absolute rules of engagement for population screening. They force policymakers to answer hard questions before they touch a healthy population.
First, the condition being screened for must be an important health problem. You don't screen for trivialities.
Second, the natural history of the disease, exactly how it develops from a latent silent phase to clinical symptomatic illness, must be adequately understood.
You have to definitively know that catching it early actually changes the final outcome. Catching a fast-moving, aggressive cancer 3 months early might not change the survival rate at all. It just makes the patient a patient for 3 months longer.
Which we'll talk about later with lead time bias. What else is on the list?
Third, there must be a simple, safe, precise, and validated screening test that is physically and culturally acceptable to the population. A test that requires general anesthesia is not an acceptable population screening tool.
Fourth, and this is absolutely critical, there must be an effective treatment available for the patients identified. This one is profound. Catching an untreatable terminal disease early doesn't help the patient. It only prolongs the period of agonizing anxiety without altering the ultimate outcome. You've just given them more time to live in fear.
Precisely. It violates the core ethical mandate of doing no harm. And finally, the program must be clinically, socially, and economically acceptable.
The facilities for diagnosis and treatment must already be in place and adequately funded before you start looking for the disease.
If you screen 1 million people and find 10,000 cases, but your local clinics can only handle 100 biopsies a month, you have created a horrific bottleneck of terror.
You've just diagnosed people and told them to go sit on a waiting list for a year. It's cruel, which perfectly sets up the actual mathematics of how we judge these tests before we roll them out.
We really need to focus on clinical reasoning here.
But let's talk about the bedrock concepts of test validity, sensitivity versus specificity.
These are the two metrics that define the inherent power of the test itself.
Let's use an analogy. Imagine you are a commercial fisherman, and you are trying to catch a specific type of tuna, but you want to leave the dolphins and the old boots in the ocean.
Your screening test is your fishing net.
Sensitivity is about the holes in the net. A highly sensitive test has very small holes. It is designed to catch all the target fish. It rarely misses a sick person. It catches the true positives.
Specificity, on the other hand, is about the design of the net ensuring it only catches the target fish and lets all the seaweed, the dolphins, and the old boots swim right through.
A highly specific test correctly rules out the true negatives. It rarely falsely alarms a healthy person.
That is a highly effective visualization. And this is where a crucial, often misunderstood public health truth emerges. If you talk to a clinician, a doctor sitting in a room with one patient, they generally love sensitivity.
A clinician is terrified of missing a diagnosis, sending a sick patient home, and having them deteriorate.
They want the net with the smallest holes possible. They will accept a few false alarms if it means they don't miss the cancer. But a public health director, looking at a population of 5 million people, is terrified of low specificity.
Wait, why? Why wouldn't the public health director want the most sensitive tests too?
Because of the math of scale. If you have a
Yeah.
test with 95% specificity, which sounds great, right? An A grade.
Yeah, sounds solid.
That means it has a 5% false positive rate. Now, apply that 5% error rate to a population of 1 million perfectly healthy people, you instantly generate 50,000 false positives.
You will completely crash your healthcare system in a week.
The diagnostic clinics will be overwhelmed. The biopsy wait times will skyrocket from days to years. The system will bankrupt itself on unnecessary tests, and you will inflict widespread panic on a massive scale.
In broad population screening, protecting the system from false positives means specificity is paramount. That makes total sense when you scale it up. You can't handle 50,000 panicking healthy people. But the math gets even more wild and honestly a bit counterintuitive when we move from the power of the test itself to how it actually performs in the real world.
We have to talk about positive predictive value, or PPV, and how it is entirely hostage to the underlying prevalence of the disease. This concept is truly a masterclass in epidemiological reasoning, and it is where many intuitive assumptions about medicine break down. Sensitivity and specificity are properties of the test itself.
But positive predictive value asks a very practical, real-world question.
If a patient sits in your office and gets a positive test result, what is the actual mathematical probability that they truly have the disease?
To understand this, let's walk through a classic example used in epidemiological training. Screening for beta thalassemia. Okay, let's walk through this slowly. Beta thalassemia is a genetic blood disorder.
Correct. And to screen for it, you can use a test that measures mean cell hemoglobin, or MCH. Now, researchers can set a specific cutoff point for this test. Let's say they set the cutoff at 27 picograms. At this specific threshold, the test has been proven to have 100% sensitivity.
100% sensitivity. So the net has 0 holes.
Right.
It misses absolutely no one who has the disease.
Exactly. It catches every single carrier. Now, imagine you deploy this perfect 100% sensitive test in a specialist hospital clinic. This clinic serves a population with a known high prevalence of beta thalassemia.
Because the disease is common in this specific patient pool, the positive predictive value calculates out to roughly 77.4%.
Okay.
So in that hospital, if the test rings positive, there's a 77.4% chance the patient actually has the disorder. That is a very useful clinical tool. You can confidently act on that result.
It is highly actionable, but watch what happens to the math. When you take that exact same test with the exact same machine and the exact same 100% sensitivity, and you deploy it in a general national population where the underlying prevalence of beta thalassemia is very low.
Okay, I take the machine out of the hospital and I put it in a shopping mall in the suburbs. What happens?
The math completely collapses. In a low prevalence population, the positive predictive value of that exact same test drops to 1.3%.
Wait, 1.3%. Are you seriously telling me a test with 100% sensitivity is wrong? Almost 99% of the time. That completely breaks my brain.
It breaks a lot of people's brains, but it is the ruthless reality of statistics. Why does it happen? Because the disease is so rare in the general population, the sheer massive volume of healthy people taking the test means that even a tiny fraction of a percent of false positives will absolutely drown out the handful of true positives.
Let me make sure I have this right. At a 1.3% PPV, that means if I run this screening program, for every 100 people who get a terrifying phone call saying, your screening test is positive, 98 of those people are perfectly healthy.
There are false positives generated by statistical noise, and only 2 actually have the condition. That is exactly what it means. The takeaway for anyone designing a health system is this. The exact same test, performed in the exact same way, goes from being highly predictive and useful in a clinic to practically useless and actively harmful in the general public, simply because the background prevalence of the disease changed.
You cannot just blindly roll out a screening test to the general public without deeply understanding the math of prevalence. That is staggering. It completely shifts your perspective on why doctors don't just test for everything, and this mathematical reality plays right into the health economics of screening.
When you have a system generating massive amounts of false positives, how do you even measure the cost effectiveness of the program?
We constantly hear terms thrown around like QALIs and dailies.
Health economics is an attempt to put a numerical value on human health and suffering to guide resource allocation. Quality-adjusted life years, or QALOIs, and disability-adjusted life years, or DALYs, are the primary metrics used.
A QELI attempts to measure not just how long a medical intervention extends a life, but the quality of that extended life. One QELI equals 1 year of perfect health.
But calculating the true cost-effectiveness of a screening program is incredibly difficult, far more difficult than pricing a new drug,
Why is that?
because of the required time horizons and the invisible costs. First, to measure the impact of screening, you require a lifetime horizon. You are asking the government to invest millions of dollars today to find a microscopic lesion that might not have killed the person for 30 years.
It is very hard to model economics across 3 decades of unknown technological advancement. Furthermore, pre-evaluations for these programs notoriously underestimate the hidden cascading costs. What kind of hidden costs? Like the machines.
Not just the machines. When governments price out a screening program, they easily calculate the cost of the plastic swab, the lab tech salary, and the mailer. But they often completely ignore the massive infrastructure required for ongoing quality assurance.
They ignore the IT systems required to track millions of patients. They ignore the cost of training tens of thousands of specialized nurses.
And most critically, they ignore the cascading costs in the wider system caused by the false positives we just discussed.
Right, those 98 healthy people who got the terrifying phone call.
Exactly. A false positive result generates profound acute anxiety. That anxiety drives the patient to make multiple urgent extra visits to their general practitioner just for reassurance.
They demand extra scans, they demand second opinions. All of that takes up GP time and hospital resources.
It is a massive hidden cost to the healthcare system that is rarely factored into the initial shiny models presented to politicians.
So what does this all mean for the people actually running the system? It means that behind every single screening program, there's an absolute minefield of ethical and governance dilemmas.
This isn't just a science problem. This is arguably the hardest decision matrix in public health. You constantly have this massive grinding conflict between utilitarianism and equity. That is the core ethical tension that public health directors wrestle with daily. The criteria used to justify screening programs, like Wilson and Jingner, are generally utilitarian.
They're designed to maximize overall efficiency, to ensure the greatest amount of health benefit for the greatest number of people given a finite budget. It's a calculus of maximum societal yield. But equity pushes back against that pure math.
It does. Equity focuses on fairness, justice, and the distribution of those benefits. For example, pure utilitarian efficiency might dictate that a screening program should only focus on the highest risk demographic, say, affluent populations in urban centers where access to follow-up care is cheap and easy.
But an equity approach demands that we consider whether that efficient strategy actively exacerbates existing health inequalities by leaving rural or marginalized populations behind. And as we move into newer forms of screening, specifically genetic screening, the ethical stakes get even higher. There's the dark historical shadow of eugenics that hangs over the entire concept of population genetics.
The history of trying to improve human genetic qualities through coercive social policy is fraught with atrocities, most notably during the Nazi era, but also in early 20th century policies across Europe and North America.
Today, as we rapidly expand antenatal genetic screening capabilities, the governance must be incredibly tight.
The consensus is that the goal of genetic screening must always be strictly informational, to provide parents with knowledge to make an informed choice about their own lives, never to mandate or pressure societal outcomes. That is the absolute ethical baseline. However, even with that baseline, medical ethicists deeply question the illusion of informed choice in routine, fast-paced health settings.
Consider a pregnant woman visiting a busy clinic. When a family doctor presents a battery of antenatal screening tests as simply a routine part of the checklist, does that patient really have the deep, nuanced understanding of positive predictive value, false positive rates, and the complex realities of raising a child with the genetic condition required to make a truly informed decision?
Often they do not. They just agree to the test because the doctor, an authority figure, offered it as standard procedure.
It's a profound responsibility placed on the clinician to ensure the patient actually understands what they're agreeing to. And to manage that massive population-level responsibility, the governance of these screening programs has to be ironclad.
You cannot just rely on an individual, overworked doctor remembering to follow up on a complex lab result. You need what public health systems call fail-safe systems. A fail-safe system is a population-oriented infrastructure that operates entirely independently of individual practitioners. It is the safety net beneath the doctors. The perfect, classy example is the cervical screening call-recall system used in the UK.
How does that actually work mechanically?
In the UK system, the central IT infrastructure knows exactly who is eligible for screening based on national demographic data. It does not wait for a doctor to order a test. The system automatically generates and sends the invitation letter.
If the patient takes the test and it comes back abnormal, the central system tracks that result.
If the patient does not show up for their required follow-up colposcopy within a specified time frame, the system flags the anomaly and automatically issues a recall notice. It chases the patient.
It does not rely on a busy GP remembering to check a paper file or a lab tech making a phone call. If a national screening program lacks these independent, automated fail-safe systems, public health guidelines are blunt. The program is fundamentally unsafe. But this raises an important question. If these programs are this difficult to set up correctly, and it is this easy to cause massive population harm through false positives and overtreatment, why is it so incredibly hard to stop a screening program once it starts, even when the data proves it isn't working?
It is entirely due to psychological resistance, bureaucratic momentum, and the popularity paradox we discussed earlier. Once a screening program is running, stopping, it feels, to the public, like a government is actively taking a lifeline away. Even if the epidemiological data definitively proves that lifeline is actually a hazard.
Because you've created a massive constituency of people who believe the program saved them.
Exactly. People who were diagnosed and treated through the program firmly, deeply believe the program saved their lives. They do not know and cannot know if they were victims of overdiagnosis whose latent tumor never would have progressed.
They just know they had cancer, they had surgery, and they are alive. They become incredibly powerful, emotionally resonant advocacy groups.
It is political suicide to argue against them with a spreadsheet of PPV statistics. To illustrate this inertia, consider two stark historical examples. First, the Japanese neuroblastoma screening program in children.
Neuroblastoma is a type of childhood cancer.
Yes. Japan started a massive national screening program for it in 1985, testing infants at 6 months old. It was hugely popular. But by 1990, international panels and rigorous data analysis concluded that the program did not actually reduce mortality from the disease.
Worse, it was causing active harm through the unnecessary surgical removal of tumors that, in infants, often spontaneously regress and disappear on their own. They were operating on babies who didn't need it. The data was clear in 1990, so they shut it down.
No. Because of the institutional momentum, the invested funding, and the emotional weight of screening babies for cancer, it took until 2004 for the Japanese government to bravely and finally shut the program down.
14 years. They ran a program for 14 years knowing it was likely causing harm to infants before they could overcome the bureaucratic inertia to stop it. That is terrifying.
It is a cautionary tale. And the Danish TB X-ray program is an even starker example of sheer bureaucratic autopilot. For decades, Denmark mandated chest X-rays for newly employed personnel at massive companies, like the Carlsberg breweries, to screen for tuberculosis.
Which made sense in the 1940s.
It made perfect sense in the 1940s, but they kept doing it, mandating it for employment, for 20 years after tuberculosis had been practically eradicated in the Danish population.
They were essentially just bombarding thousands of perfectly healthy young workers with completely unnecessary radiation every year for 2 decades out of sheer administrative inertia. Nobody wanted to be the one to sign the paper ending the safety program, which is exactly why independent external evaluation boards are so critical. The administrators whose budgets depend on the program running will never be the ones to shut it down. You need outside umpires.
Precisely. Governance must be separated from operation.
Okay, so let's take all these heavy frameworks, the math of prevalence, the ethics of informed choice, the biases, the inertia, and apply them to some rapid pattern recognition. Let's sweep across the human lifespan and look at the specific screening debates highlighted in modern epidemiology, starting right at the beginning, antenatal and newborn screening.
In the newborn phase, we use heel-prick blood tests to look for metabolic and genetic conditions like sickle cell disease and cystic fibrosis. The goal here is pure, immediate intervention, catching a condition in the first weeks of life where early dietary changes or medications can prevent profound disability or death.
But a specific modern debate arises because the advanced genetic testing methods we use to find the disease also inadvertently identify carriers.
These are infants who have one copy of the gene, meaning they will never actually develop the disease themselves, but they could pass it on to their future children.
So you test a baby to see if they're sick, find out they're perfectly healthy, but you accidentally discover a genetic secret about their future reproductive life.
Exactly. And the ethical debate centers on what to do with that information. Do you reveal this carrier status to the parents? You are burdening them with complex genetic information about a child who cannot yet consent to knowing it.
The prevailing view in health systems like the UK and the US has leaned toward disclosing the information to the parents.
However, doing so ethically requires massive systemic investments in genetic counseling. You must ensure the parents deeply understand the difference between being a healthy carrier and having the disease. Otherwise, you inflict years of unnecessary anxiety on the family.
Then we move into the adult years, and this is where the cancer screening debates get incredibly intense and publicly fraught. Let's look at breast cancer screening. It is incredibly popular, practically a cultural institution. But epidemiologists constantly debate the trade-offs.
They do. The debates center on the cumulative risks of radiation exposure from decades of mammograms, the severe psychological trauma caused by the high rate of false positives, and the very real issue of overdiagnosis leading to unnecessary lumpectomies or mastectomies.
It is a razor-thin margin of benefit versus harm, which is why independent panel reviews are constantly required to recalibrate the age guidelines and frequency to ensure the utilitarian math still holds up. And then there is cervical cancer screening. The data on this is just mind-blowing in terms of the scale required to save a life. There was a massive 2004 analysis out of Bristol by a researcher named Raffel. To prevent just one single death from cervical cancer, they calculated the sheer volume of intervention required.
The numbers perfectly encapsulate the utilitarian trade-off of population screening. To prevent one death, approximately 1,000 women need to be screened continuously, returning for smear tests every few years for 35 years.
Out of those 1,000 women, over 150 will receive an abnormal result at some point and face the acute anxiety of that call.
Over 80 of them will be referred for invasive investigation, like a colposcopy, and over 50 of them will undergo physical treatment, having tissue removed or ablated for precancerous lesions that statistical analysis suggests in 80% of cases would never have actually progressed to invasive cancer in their lifetime anyway.
So you treat 50 women, 40 of whom didn't actually need it, to ensure you save the one woman whose cancer would have been fatal. That is an enormous societal effort and a significant amount of overtreatment. But as a society, we have looked at that math and deemed that specific trade-off acceptable to prevent the horror of advanced cervical cancer.
We have. However, prostate cancer screening presents a radically different scenario. When you look at the epidemiological consensus on screening asymptomatic men using the PSA blood test, the math does not hold up. The rate of overdiagnosis is simply too massive.
Prostate cancer is incredibly common in older men. But as the clinical adage goes, many more men die with prostate cancer than of it. It's often a very slow-moving tractor.
Exactly. Systematic population screening with PSA tests finds thousands of these slow-growing tumors that would never have caused the man any symptoms or shortened his life. But finding them triggers a cascade of interventions.
It leads to radical prostatectomies and radiation therapies that frequently leave men with lifelong incontinence and impotence.
And rigorous trials have shown that this massive wave of morbid overtreatment provides negligible, if any, overall population survival benefit. Therefore, the conclusion is that there is no case for a national prescriptive screening program for asymptomatic individuals.
And finally, looking at the very end of the lifespan, the elderly, how does the strategy change?
There is a definitive shift. As people reach advanced age, the value of systematic, disease-specific population screening for latent diseases like cancer decreases significantly because competing mortality risks take over.
The strategy shifts away from prescriptive screening and back toward opportunistic case finding.
When an elderly patient visits their primary care doctor, that is the time to actively look for immediate issues that impact their daily quality of life.
The clinician should be opportunistic, checking for fall risks, assessing for social isolation, testing vision and hearing, and critically, reviewing their prescriptions to eliminate inappropriate or compounding medications. The goal shifts from hunting for latent disease to actively maintaining function and independence. And as we review all these cancer screening paradigms, before we finish, we absolutely must equip you, the listener, with a crucial differentiation in clinical reasoning. When you are reading medical literature that claims a new screening program doubled survival rates, you have to know how to spot the illusions. You must understand length time bias versus lead time bias. These two biases constantly confound the evaluation of screening trials.
They are the twin ghosts that haunt observational data. Let's start with length time bias. This bias occurs because tumors in a population do not all grow at the same speed. Let's use your vehicle analogy.
Fast-growing, highly aggressive tumors are like speeding sports cars on a highway. They zip through the preclinical detectable phase very quickly and rapidly cause symptoms. Because they are moving so fast, they are in the catchable window for only a very short time.
Slow-growing indolent tumors are like slow-moving tractors. They spend years, sometimes decades, trundling along in the detectable asymptomatic phase.
Okay, sports cars and tractors.
Now, imagine a screening program is a camera taking a single snapshot of the highway. When you take that snapshot, which vehicles are you mathematically much more likely to catch in the frame?
The tractors, because they are on the road for so much longer.
Therefore, a screening program disproportionately catches less aggressive, less lethal tumors. This makes the screening program look incredibly successful on paper. The researchers say, look at all these people we diagnosed who are surviving for years.
But it is an illusion. The program didn't make the cancer less lethal. The program just systematically selected for the least aggressive diseases that were already highly survivable. That is brilliant. It artificially inflates the survival statistics of the screened cohort. And what about lead time bias?
Lead time bias is an even more insidious illusion of extended survival.
Yeah.
Imagine a patient who has a specific cancer. Biologically, this cancer is destined to inevitably cause symptoms when the patient is 65, and it will inevitably lead to their death at age 70. From the moment of clinical diagnosis at 65 to their death at 70 is exactly 5 years.
Okay, 5 years of survival time from diagnosis.
Now, imagine a screening program is introduced. It detects that exact same cancer early, while it is silent when the patient is 60. The patient receives early treatment. However, let's say the treatment for this specific cancer is ultimately ineffective. The patient still dies at age 70, exactly as their biology destined. But look at the statistics now. The time from the new early diagnosis at 60 to their death at 70 is now 10 years. So the screening program will publish a paper claiming they doubled the survival time from 5 years to 10 years.
Exactly. They will claim a massive victory. But they didn't extend the patient's life by a single day. They merely advanced the time of diagnosis. They started the stopwatch earlier. In reality, all the screening program achieved was forcing the patient to live 5 extra years with the agonizing, terrifying knowledge of their terminal disease without offering any actual life extension. Wow. Length time bias catches the slow ones, making the disease look milder. Lead time bias just starts the clock earlier, making the survival time look longer. If you don't adjust for those in a study, the data is basically useless. That is vital for evaluating any medical literature. Okay, before we wrap up this massive deep dive, it's time to solidify those neural pathways. We have 6 rapid, single best answer prompts based on the frameworks we've built today. We'll pause after each question so you can lock in your answer in your head. Let's go. Question 1. In the context of population screening, what metric is most heavily dependent on the baseline prevalence of the disease in the target population? I'll give you 3 seconds to think. 1, 2, 3.
The answer is positive predictive value, or PPV. As we saw with the beta thalassemia example, moving a test from a high-prevalence hospital to a low-prevalence general population plummets the PPV, leading to a massive flood of false positives. You can review this math in Chapter 11.4 under Properties of Screening Tests.
Question 2. Which bias occurs when a screening program appears to improve survival time, but in reality it merely advanced the time of diagnosis without changing the ultimate time of death? 3 seconds. 1, 2, 3.
That is lead time bias. It just starts the diagnostic stopwatch earlier without pushing back the finish line. This crucial concept is detailed in Chapter 11.4 under cancer screening.
Strangely, what was the primary structural difference that led to higher efficacy in the Stanford 3 community studies intervention groups? 3 seconds. 1, 2, 3.
The answer is the addition of intensive, face-to-face risk reduction classes targeted at high-risk individuals, implemented alongside the general mass media campaign. It amplified the risk reduction from 23% to 30%. Reference Chapter 5.9, the first decade of CVD projects.
Question 4. When implementing a public health intervention, what concept describes the shift from relying solely on individual clinical willpower to altering local agricultural policies, work sites, and school environments? 3 seconds. 1, 2, 3.
That is the ecological imperative. It requires denormalizing the behavior by re-engineering the physical and economic environment, as seen in the North Karelia dairy-to-berry transition. You can find this in Chapter 5.9, Lessons Drawn from 7 Decades.
Question 5. True or false? According to the Wilson-Jungner criteria, a highly sensitive and highly specific test is sufficient justification to launch a national screening program. 3 seconds. 1, 2, 3.
False. A mathematically sound test is necessary but not sufficient. There must also be an effective treatment, proven cost-effectiveness, and the clinical infrastructure to handle the diagnoses already in place before screening begins. Reference Chapter 11.4, Criteria for Introducing a Screening Program.
Question 6. Which foundational public health metric tracks the occurrence of strictly new cases of a disease in a population over a specified time period? 3 seconds. 1, 2, 3.
Incidence. Remember the water metaphor. Incidence is the new water flowing from the faucet, determining the immediate risk. This was our core differentiation framework applied right at the start. If we step back and connect all of this to the bigger picture of where medicine is heading, as we move rapidly into an era of cheap, instant, and highly personalized genomic sequencing, our ability to scan the human body will become nearly infinite. The ultimate test of public health in the 21st century won't be our technological ability to find microscopic abnormalities. Our greatest challenge and our greatest ethical burden will be having the immense discipline to know which abnormalities to completely ignore, protecting perfectly healthy people from the anxiety, the overtreatment, and the harm of unnecessary medicine.
That is a profound and incredibly necessary thought to leave on. Thank you so much for joining us in the deep end today. We highly encourage you to review the Oxford chapters to solidify these frameworks, draw your own connections, and keep challenging your assumptions every time you look at a clinical trial. Until next time, keep diving deep. Here are the details of this episode.
Community intervention trials in high-income countries. Byline. Testing prevention at scale, translating evidence into organized systems. Episode description. Community intervention trials in high-income countries often operate within structured health systems, established institutions, and robust regulatory frameworks. This chapter examines how large-scale public health strategies are designed, implemented, and evaluated in these settings. We explore classic and contemporary examples of community-based trials addressing. Cardiovascular disease prevention. We explore classic and contemporary examples of community-based trials addressing smoking cessation campaigns. We explore classic and contemporary examples of community-based trials addressing school-based nutrition and physical activity programs. We explore classic and contemporary examples of community-based trials addressing screening and early detection initiatives. We explore classic and contemporary examples of community-based trials addressing environmental health interventions. We explore classic and contemporary examples of community-based trials addressing. These trials often involve coordinated efforts between government agencies, healthcare providers, schools, media outlets, and civil society organizations. We explore classic and contemporary examples of community-based trials addressing. The chapter highlights both achievements and limitations. Some large-scale programs demonstrate measurable shifts in risk factor prevalence. Others show modest or transient effects. Key challenges include behavioral sustainability. Key challenges include measuring population-level change. Key challenges include secular trends influencing outcomes. Key challenges include political and economic pressures. Key challenges include high-income contexts offer infrastructure, data systems, and analytic capacity, but they also face entrenched behaviors, industry influence, and complex policy environments. Key challenges include community intervention trials in these settings test whether structured systems can shift population health at scale. Key challenges include they bridge research, governance, and societal change. Key challenges include key takeaways. Key challenges include high-income settings enable large, coordinated interventions. Key challenges include infrastructure and data systems support evaluation. Key challenges include behavioral change is difficult to sustain. Key challenges include secular trends may confound outcomes. Key challenges include industry and policy environments influence results. Key challenges include multi-sector collaboration is essential. Key challenges include evaluation must account for system complexity. Key challenges include population-level impact requires long-term strategy.